Carlos, how we doing?
How are you, Dr. Pascual?
Good, good. Do we have Milos?
Yeah, he's here.
Yes, sir.
The presenters are also here.
Good. Everybody tested audio and video?
Yeah.
Outstanding. I'm sorry I'm late. Is Antonio on here?
So I didn't see Antonio, and Dr. Chiodetis she got stuck in the OR and she won't make it. So I asked Dr. Untrak to be a panelist today on her behalf.
Perfect. All right, so let's get started. Is that all right, Milos?
Yes, sir. We had some extra people jump on, so it's perfect.
Yeah.
Wonderful. I want to say very much. My name is Jose Pascual. I've worked with Antonio to get this initiative started. It's been going on for more than a year, although the PTS has been doing this for over 13 years. So I'm going to defer to our two moderators, Milos and Carlos, to get the meeting started. Go ahead, gentlemen.
All right. Thank you, Dr. Pascual. So me and Dr. Milos, we're going to moderate this session on behalf of the AAST and the Pan American Trauma Society. Today we have two presentations. The first one will be Dr. Dr. Varopas. I hope I got this right. He's a surgeon, a trauma surgeon in critical care unit, Department of Surgery and Faculty in the Chiang Mai University in Thailand. And we'll have also Dr. Mariana Fonseca from Brazil. She's a general and trauma surgery at Hospital de Pronto Socorro de Porto Alegre in Brazil, which is a state in the south of Brazil. So we are going to have three panelists today. The first one is Dr. Adenauer Góes. He's also from Brazil, and he's representing the Brazilian Trauma Society and the Pan American Trauma Society. He works at the Centro Universitário in Pará, which is a northern state in Brazil. Also, we will have Rebecca Schroe. Dr. Rebecca is trauma and acute care surgeon from Auckland City Hospital, Auckland, New Zealand. She's associate professor of surgery at the University of Auckland, Australia and New Zealand Association for the Surgery of Trauma. And we will have also Dr. Stephen Untrak, who is a trauma surgeon and well known from the Pan American Trauma Society meetings. He's one of the people that are more present as panelists in our meeting. So we're very happy to have all the three of you in this meeting today. So I'm now going to pass to Dr. Milos, who is going to moderate the session from the AAST side. And the second case will be presented by Dr. Mariana.
Thank you very much, Dr. Mancoso. It's my pleasure to introduce Dr. Varopas, who is joining us from Thailand, along with all his esteemed colleagues. Sir, if you would like to share your presentation, we look forward to listening to your case.
Sure. Thank you for the introduction. I will make sure to pull it up. Okay. Okay, do everyone see my slides? Is it coming up?
Yes.
Okay. My name is, as you introduced, my name is Dr. Varopas. I'm a trauma surgeon in Chiang Mai University in Thailand. It is my pleasure to do a case presentation for the International Case Conference today. Okay, so let's begin with the case. The case history was, the patient was a 17 years old female. She was shot by unintended crossfire by a drunk shooter while she was playing in a Songkran festival. And then she was first transferred into a 130-bed hospital with only one surgeon available. And the primary survey at that first hospital was the air was patent, the breathing was okay, and the blood pressure was 150, the heart rate was 100. Her GTS was 15. She was answering questions. And for the abdominal exams, she got gunshot wounds at the epigastrium with signs of peritonitis. And the ultrasound found that the patient's got the intra-abdominal fluids, but no pericardial effusions. There are no exit of the bullets. So this is the distance between the first hospital and the nearest trauma center. So it takes 5 hours to reach the trauma center. And the distance was like 150 miles. So I will have the floor starting to think that if there are at the first hospital, you will go on to do an explore lab, or you will do some workup, or you will just transferring the patient to the trauma center because you are only the one surgeon available in that hospital. Okay. And yeah, so anyways, the surgeon at the first hospital didn't perform scans, but they perform an explore lab for the patients because the patient was developing the peritonitis with fever, and then the abdominal pain was too severe, and he afraid that if they take too much time in referring the patients to us, it will get worse. So the findings that from the first hospital was the patients got through and through gastric injuries, and there are some oozing bleeding from around the pancreas area, and they found they have zone 1 retroperitoneal hematomas, and the arrow is the area around the pancreas with some hematoma in it, which is not explored. Do you want me to give like the discussion to the floor? And if you were in that hospital, if would you like, how would you manage the patient if you are only one surgeon available?
Yeah, now is probably a good time just to ask our colleagues, Dr. Schroll and Dr. Gausch, because I know that, he deals with this routinely. Anything else that either of you would like to see in this patient before you proceed to the operating room in terms of additional work?
So if I may contribute with this, I think it's very important to say that it's not always possible, but according to the last AAST guidelines on abdominal vascular injuries, if the patient is stable enough, even though you already have the indication to perform an exploratory laparotomy, you should perform, if possible, CT with intravenous contrast. So if it was done and you have the images, it can help you exclude or confirm, for example, a superior mesenteric artery injury in this region or other associated injuries. So my question is, did you guys perform a CT before taking her to the operation?
No, I mean the surgeon at the first hospital didn't perform a CT scan, but it took the patient into the operating theater because of the peritonitis.
Go ahead,
I would be interested to know what the you've told us a bit about the operative capability. There's one surgeon here, but I would like to know sort of what the additional capabilities of this hospital are. What is the blood bank capability in terms of the amount of blood available to transfuse this surgeon or to transfuse this patient? Is there any other surgical backup available? There's a general surgeon? Is there a vascular surgeon? Is there anybody else who can assist with this?
No, the only one surgeon available is the general surgery, and actually there were another college which is also a general surgery as well, and he is not around here. And for the blood transfusion, they didn't have more than 20 units of blood and all the components altogether.
20?
Yes, 20.
I think to Dr. Pasquale's point, I agree. Even with the AAST guidelines in the presence of peritonitis 1 hole, the only other additional information that I would like here is some sort of imaging series to see where that bullet could have ended up. Because if it's ricocheted and gone up into the chest, and you've gone into the belly and everything looks okay and your patient's dying and you haven't looked in the chest because you've not known to do that, I think that's probably an important thing to include as part of the initial workup. CT scan, in my opinion, not necessary. But please continue.
Yeah, I totally agree with you. So, but yeah, they're like at a point of no return here. So yeah, so the first surgeon was doing a repair of the through and through gastric injuries, and then for the bleeding around the pancreas, they were packed with some swabs, and then for the retroperitoneal hematoma zone 1, they didn't explore it since they're thinking that it's out of their capabilities, and they perform a temporary abdominal closure and then refer to our trauma centers. Okay, and yeah, and another 5 hours passed, and the patient reached our trauma bay. So we do a re-evaluation of patients. She was intubated, and the blood pressure was stabilizing, is around 138, and the heart rate was 86. And we checked the temporary abdominal closure. There were like 1 liters of blood, and it is not active. This is on the right is how we do an temporary abdominal closure in our area. And the GCS was good except for the intubation. The content from the gastric content rolls of fresh blood, and the chest X-ray were clear. We see a bullet buried in her body, and the folates draws as a yellow urine. So this is a chest X-ray of the patients. As you can see, and there are bullets inside her bodies, and there are some swabs here. So the trajectory was on the from the epigastrium to the right side of the patients. So yeah, we then perform a scan. Yeah, we perform a scan to see if there's any vascular injuries involved, or there are some additional injury that we cannot see, or it is better to be, I mean, better to take, better than taking the patient to directly to the re-explore lab without the planning. So we perform the CT scan. I will run you through it. This is the arterial phase. I'm sorry. Does anyone has the questions? I think.
If you just run through it, and then while you're running through that, Dr. Pasquale, yes, sir.
No, I would like to ask Dr. Shaw and Dr. Marino if they were the trauma center receiving a patient with a GSW to zone 1 retroperitoneal hematoma not explored, hemodynamically stable 5 hours into it, would everyone just go to a CAT scan, or would anybody explore as the first line?
5 hours into it and hemodynamically stable, I would definitely get a CT before diving back in.
CTA or CT with contrast?
CTA.
Okay. As you can see in the arterial phase of the CT scan here, the IVZ is enhancing here, which shouldn't be enhancing in the arterial phase, right? And there are something connected here in the right from the right renal vein to the right renal artery, and we will see it better on the venous phase. As you can see, the bullet is buried in her back on the right side. And yeah, for the pancreas, we will look at the venous phase here. Okay, let's move into the venous phase. For the venous phase, we can see the hematoma at the retroperitoneal area, especially at the right side. And of course, we see the contrast was rushing out from the right renal vein and connected to the right renal artery here. And there are some laceration of the pancreas at the head on the right side of the SMV, and the remaining portion of the pancreas was the small portion remaining on the right side. And as you can see, the kidney on the right is devitalized. So that's mean the right renal artery has to be injured somehow. But for another injury, we didn't see anything else. So from a CT scan, we can see that the trajectory of the bullets should be around here, and move passing from the epigastrium to the right side of the patients. And from the CT scan, we can see that there are some pancreatic laceration that I told you that is got some small portion of the head remaining, and there are some connection between the right renal vein and the right renal artery. So that's why we suspect that there's some AV fistulas, and the kidney on the right side is devitalized. So after you saw a CT scan, you guys have any management suggestions here?
Well, I think if it depends. If I had this case in a hospital where I had endovascular capability and the patient is relatively stable, you can do a selective angiography of the renal artery and put there a stent graft. But this patient has to be treated. If you don't have endovascular capability, I would take this patient back to the OR and explore, but it has a high risk for hemorrhage, and eventually nephrectomy is going to be needed.
Yeah, I agree. I think endovascular techniques may be helpful to try to gain some endovascular control of the bleeding so that it's not so challenging when you go back. But the kidney looks like it's going to need to come out. She needs a good exploration to look at the pancreatic head and see if there's an injury to the pancreatic duct, or if anything will need to be done there. The duodenum needs to be looked at really closely because it may also be injured. Yeah.
Dr. Tavares has had a question about whether or not anybody thought there would be a potential role for Reboa here in this patient, especially with the transfer and the initial exploration. Any thoughts from anybody about prophylactically placing a Reboa?
I can comment on that. The indications for Reboa are bleeding, trauma limited to the abdomen in a non-responder. So, and is a thin young woman. For the 5-hour transfer, Reboa would be difficult to use because they would have to intermittently deflate it, and you just can't keep it inflated in zone 1, which is where it would need to go in this case. But it would be reasonable while she's still normotensive to put a right femoral arterial line so that if she did decompensate, you can quickly insert a Reboa, get control, and then take her to the operating room. So, but it wouldn't, I might do that, but not go right away to inserting Reboa in this case.
Thank you. Go ahead, Dr. Varopas.
Okay, yeah, we were thinking the same. I mean, we can use the Reboa for the zone 1 occlusion in controlling, proximal controlling if we need to explore the right renal artery or something like that. But for the endovascular treatment, we don't have the availability of the endovascular treatment at that time. So as you all have been discussed, we need to go in and do an re-explore laparotomy again. Yeah. So the operative findings on here, as you can see on the left side of the screen, there are some suture line at the stomach here, and on the right side of the screen, there are blood all around the lesser sac. And if we are going to identify it, we will see that the head of the pancreas was transected, and the hematoma is, all around the head, and the pancreatic neck is torn apart on the right side of the screen. And we further look at the retroperitoneal hematoma, which is like quickly extended to like almost on the zone 2s and all around the kidney. So we do an exploration, and we found that there are some through and through IVC injuries. That is, and after we control it, and the IVC injury was on the junction between the right renal vein and the left renal vein, and there are some bleedings coming out below, underneath the right renal vein. So, how do you deal with these findings, or anyone want to give an opinion of how you deal with these findings?
I think this is always a great question, especially for trainees that have never seen through and through IVC injuries in challenging areas. So Dr. Stroll, Dr. Gausch, how do you manage these injuries where you have both an anterior and a posterior wall defect?
Well, in my opinion, the problem is already huge when you have only the inferior vena cava injury. But because we now have the CT, we know that there is an arterial communication to the venous system. And this is very important because if you only occlude the vena above and below the injury, it's not going to stop bleeding because it is receiving blood from the arterial system. So that's a huge mess. Ideally, well, you need to control both the vein above and below and the artery. In theory, you can put a clamp in the origin of the right arterial, on the origin of the right renal artery. But this is mainly on theory because the hematoma doesn't make it easier. So if necessary, you need to clamp the aorta supraceliac. I think the important thing here is to remember that there is no safe place between the renal arteries and the superior mesenteric artery to do this in an emergent setting. This is very hard to do. So it's easier to go supraceliac and close the aorta there if you are not able to cross-clamp the origin of the renal artery. And then you have to control the vein below and above and try to suture. And sometimes you need to widen the anterior injury in the venous wall so you can suture the posterior one. And the other thing that is useful is that the right renal vein is usually lower than the left one. So in sometimes you may be able to ligate the inferior vena cava, maintaining the patency of the left renal vein in order to save the life and sacrificing the right one. So it all depends on the moment, but these are my thoughts right now.
Yeah, I agree with those thoughts completely. The only other thing I would add is I think someone in the chat had kind of suggested, would we consider renal salvage? And I think I would say this patient is at the point where renal salvage is not an option. We're trying to salvage the patient and the kidney's going to go.
Although I would say it depends on the status of the kidney. If it's clearly not salvageable, I would agree. Otherwise, I suppose there's an option for auto transplantation if the patient is stable, or the kidney can be maintained and then replaced later because she's so young. And then the other point about the talk about the Reboa, if arterial A line had been placed, that's another option for getting control of the aorta, as Dr. Goes mentioned. Instead of having to free up above the abdomen in the upper epigastrium, just put the Reboa up for that purpose in zone 1 until you get control of the right renal artery. And then I agree that the management here is to sew the back wall from the inside. So open up the anterior wall and then place the first knot posteriorly outside and then sew it from the inside, the way the transplant surgeons do routinely.
I always have nightmares about right-sided kidney injuries because of the anatomy of the artery. If I had to choose, I'd take a left injury any day. But to Dr. Pasquale's point, what did you guys find on exploration? Because I see your diagram here, but we have not yet discussed, you mentioned an AV fistula on imaging. What did you guys find in terms of the injury to the right renal artery?
So at first, it would be super difficult to identify it because of the bleeding from the cavar and the bleeding around the posterior from the caval because of the right renal artery injuries. So as you can see, there are the right kidney is devitalizing, and the intraoperative, the kidney is starting to get a little pale, and so we think the kidney was not salvageable. So we quickly, okay, that's what we do. What we did is after we explore the IVC, so we control the right renal veins. The left renal vein has to be controlled as well because it's in the junction, right? So, and we perform a right nephrectomy to get control of the right renal artery and right renal vein as well. So then we primarily repair the IVC using the method you all discussed. And I will show you the picture after that. And we like it, the right renal artery, because after we do a right nephrectomy, we can identify the right renal artery, so we can ligate it. And then, but after all these procedures, the patients lost like almost 7 liters of the blood, and she developed the acidosis and hypothermia, about 89.6 Fahrenheit. So we need to do a temporary abdominal closure with a drainage of the pancreas, and then we're starting rewarming in the ICU. This is how we repair the IVC as you discussed. I'm not getting a photo when I repair it because of the messy it is it happening. So we extend the anterior perforation, and we're starting to suture the posterior perforation first, and then we're closing the anterior perforation. On the right side is the IVC after the repair. Yeah, the lumen was compromised a little bit, but it was working. So, and the patient got like unstable. So we have to take the patient out from the operating theater to resuscitate it in the ICU. Okay, let's move on to the next one. We perform a rotem as well, and they show out the platelets and the factors that is lacking. So we group the components that is required for transfusion for the patients. And now, after we resuscitating the patient, she was getting better. Her vital signs were normalizing. He was out of the inotropic ducts, and the acidosis and the temperature was normalizing as well. So now we are planning for a definitive treatment. You guys, do you all have any ideas on what you're going to do next?
Dr. Scholl, Dr. Goshen, where sounds like we've temporized at least the kidney and the artery and the vein injury, and we haven't really addressed anything with the pancreas. Where would you like to go next?
Right. So is it? Yeah. Do you have any ideas on how what you're going to do after that, or anyone have any comments?
Yeah, I would say that the condition of the patient's improving, so she's I take it no longer septic, and then her hemodynamics are good. She's not on vasopressors, and she's probably being able to be weaned off the ventilator. So if her overall status is good, she's in good shape. You can do a proper anatomic investigation, looking at the pancreas, that the drains are still there. What's coming out of the drains? Are you getting amylase? And then at some point, I would consult the gastroenterologist, see if they would do an ERCP versus MRCP in this case, just to see the anatomy. And apparently, the neck was totally was disrupted. So the issue is, can you go back electively? And what kind of reconstruction would you do? Would you do a total distal pancreatectomy versus getting control of any potential disruption of the duct with a Roux-en-Y limb or resection of the tail? Those are the decisions you need to make. So I would concentrate on that anatomy. But if her condition is good, she doesn't have a big fistula, and there's no abscess forming, I think you're ahead of the game, and you can proceed more deliberatively and in planning.
Okay, so it is as you said. We didn't exercise the anatomy, the injured anatomy of the pancreas yet. So we perform the MRCP to define if the main pancreatic duct was still okay and the bile. I'm sorry. To identify the bile duct is still okay and the pancreatic duct is still okay because it changed the operating reconstruction of the pancreas. And I'll run you through it. On the right side, you can see some collections here on the pancreas, and for the bile duct is coming out okay. And you can see there's no leakage from the bile duct, so there is one good thing for that. And I will let you have a look at the reconstruction. This is another wheel. As you can see, there are some collections here of the contrast. And after we perform a reconstruction, we suspect that the transection of the main pancreatic duct and head was suspected, but the bile duct is working properly. So yeah, it's time to make a decisions for that injury. So if it was you, what are you gonna do with the reconstruction?
Dr. Stroll?
This patient's stable. I would ask one of my gastroenterology colleagues to see if they would be able to try to do an ERCP and get a stent across that pancreatic duct injury to limit the leaking, leave some wide drains, and hope that that manages it and that it will heal up. Because if it's really proximal, then you can't do a distal pancreatectomy. Your surgical option is basically a Whipple, which is huge comorbidity and very high risk for complications.
Okay, it was exactly our idea as well. So we do an endoscope to perform it to help because the laceration was in the head. So if it can be cannulated through the ampulla, it should be like easier than the tail to insert the stent. But you remember on the first hospital to repair the stomach at the prepyrolas area, right? So that makes the scope cannot pass the repair site to the duodenum. So it was super swelling in the prepyrolas area. And yeah, the scope cannot pass this to perform a proper ERCP and insert the stent. So we got no choice but to do some open reconstruction of the pancreas. Okay, so it was unsuccessful because of the stenosis of the pyrolas. Okay. And then after we perform the Explore lab again to do the reconstruction, you can see here, I will level you through the pancreatic head has a hole in it when hematoma resolved, and the duodenum was fine, and compared to total of the pancreas, there was less than like 15 or 20% remaining, and the remaining part had holes in it. And for the IVC that we repaired, it was working properly, so we didn't pay much attention to it. So this is time to make a decision for the reconstruction here. Okay. After we found that the remaining part of the head was, should be not good because of the hole and the laceration in it, then we perform covering the retroperitoneum with the soft tissues, and then we perform a Roux-en-Y pancreatojejunostomy with a gastrojejunostomy to help with the feedings. It looked like this. We do a pancreatojejunostomy by dunking because we could not find the main pancreatic duct. Okay, so we have to dunk it in the jejunum, and we did do a Roux-en-Y anastomosis as well. It was final configuration was look something like this. Yeah, it has PJ anastomosis, the gastrojejunostomy, and then jejunojejunostomy, and of course we have to remove the bullets from the patients on the back. Okay, do you have any discussion here?
Can I just ask, did you divide the pancreas at the injury site? And it looks like you did an end-to-end pancreaticojejunostomy. Is that?
Yes.
Yes. Okay. So, and then you just oversewed the
Yes,
pancreatic.
we oversewed the proximal and put a drain in it.
All right, because the other option would be just to sew the do an anastomosis over that open area into the scar, and and avoid the dissection. But this worked well.
Like
For
a
you.
serosal patch?
I'm sorry.
Like a serosal patch?
Well, actually, an actual anastomosis. So any pancreatic fluid draining would just drain into the. It'd be still a Rouen-wide pancreatic angiogenosty, but a side to side instead of an end to end with oversewing of the dividing of the neck and oversewing of the head side.
Gotcha. Okay.
I have a question. What did you do to protect your IVC repair from pancreatic leakage down onto it? Because that could be disastrous.
Yeah, of course, a good question. So we're covering it with we would bring some omentum or soft tissues to cover it, and when we put a drain in it to prevent the pancreatic juice leaking to cause the damage to the IVCs. Yeah.
Speaking from firsthand experience, it is very disastrous. Yes, Dr. Pasquale.
Dr. Varopas, you connected the jejunum to the hole in the head of the pancreas. You did not resect the head of the pancreas. No, that is not what you did.
No, the head and the tail was disconnected from each other. We just oversew the distal part of the head, and then we do an anastomosis with the tail. And the jejunum with the tail.
So the hole was not.
Without resecting the head, okay?
Yes, without resecting the head. Just drain it. Just put a drain in it.
So why not do a distal pancreatectomy?
Yes, it was in the consideration too, because if we do a distal pancreatectomy and the patient is still at a very young age, and the remaining part of the pancreas is so little and they have holes in it, so it may be not working properly. The remaining part shouldn't be working properly, so the patient can develop the endocrine and exocrine function after that. So that's we estimate that the remaining part shouldn't be working properly, so that's why we decided to preserve the tail for the functions.
I think for me, the fear of a pancreatic leak with now jejunal pancreatic anastomosis would be something I would fear more. And it also would take a lot more. I think I would agree with Dr. Scholl that essentially you're tolerating like a Whipple type of situation, even though you still have the head there. I would have done a distal pancreatectomy despite his young age. I don't know. Maybe it's oversimplistic.
Yeah.
Okay.
It's an excellent point of discussion about how to manage these sort of devastating injuries right at the head, neck area, and what sort of function we leave the patient with, especially in the presence of concurrent vascular injuries and the potential for having that suture line break down and having the patient exsanguinate on the floor. Thank you so much to Dr. Varopas and his team and the general surgeon who was brave enough to dive into that abdomen. I think that is an excellent thing that, at least here in the States, is something that we need to learn from, that just because you're in a small center, if you can do something, you should at least try and do something depending on your resources. In the interest of time, I'm now going to hand over to Dr. Mengozo and our PTS team so that they can get started with their presentation.
Yeah, thank you so much.
Thank you so much.
Yeah, great case, Dr. Varopas. Thank you very much. So now we're having Dr. Mariana Fonseca presentation. So Dr. Mariana, please, whenever you are ready, you may share a screen and start the presentation.
Okay, good afternoon. My name is Mariana. I am a trauma surgeon from Brazil. I would like to thank you for the opportunity to present another case in this meeting. This case presentation is again on behalf of the Brazilian Trauma Society. So let's begin our discussion on the critical junction, distal esophageal trauma. So our patient is a 51-year-old male who was brought to the emergency department by police officers. They reported a transfixing gunshot wound to the chest about 30 minutes prior to his arrival. The entrance wound was around the fourth intercostal space on the right, mid-axillary line, and the exit wound was around the seventh intercostal space. Also lateral, anterior, mid-axillary line. Upon arrival, he had low oxygen levels. He had palpable subcutaneous emphysema. His heart rate was 82 beats per minute. He was hypotensive. He had also cold and clammy extremities. His capillary refill time was over 5 seconds. He was conscious and reported diffuse abdominal pain. The EFAST showed a small bilateral hemothorax and bilateral lung sliding. So he was put under supplemental oxygen. He began crystalloid infusion, 500 cc's of ringer lactate, and he got a little better. So he underwent a chest and abdominal CT scan. I don't know if anybody would do something different.
Well, let's see. Dr. Untracht, would you do anything different?
No, I think that's fine. If he only got 500 cc's of crystalloid and he stabilized and you were confident that I think that's reasonable, but I wouldn't, as you did here, I would do as you did, not give much more than 500 cc's or a liter at most before switching to blood. But I think that's good management.
Excellent. Dr. Adenauer, any comments?
I think Dr. Utrecht already said everything that needs to be said here.
Great. Dr. Schro, anything to add?
I'm just wondering if I missed it, but did you get a chest X-ray before you went to CT scan?
No.
So confirm that this is in fact just one bullet tract and you don't have two separate injuries or bullets in other places you don't expect?
No, just the EFAST.
And confirm that the pneumothorax is small and you don't need a chest drain before you go to the CT scanner?
Yeah. He had a bilateral lung sliding despite the subcutaneous emphysema, and he got better with the supplemental oxygen.
Yeah, I would I agree with Dr. Go. I just have a very low threshold for a patient with a pneumothorax that I can see on chest X-ray. I would be inclined to put a chest drain in that patient before they go to the scanner because you don't want them to tension in the CT scanner. But I understand that sometimes with small ones it winds up okay and they don't need one in the scanner. But I would have a very low threshold to take that out of the equation before they go.
And Dr. Mariana, just to confirm, so no pneumothorax, but bilateral hemothorax. Is that correct?
Yeah, they didn't see, they saw bilateral lung sliding. There was no reported lung point or anything.
Perfect. Okay, I think you can go on.
Okay, so this is the lung phase. So we can see that he actually had a bilateral pneumothorax, though it was small. Bilateral hemothorax, which was bigger in the right, subcutaneous emphysema, and significant pulmonary contusion along the trajectory of the bullet. And he also had free air in the abdomen. This is the portal phase. So we can see again the hemothorax. And it appears that the aorta was not compromised and the trajectory was, the bullet crossed the mediastinum in the projection of the esophagus. In the abdomen, I will come back a little bit. There was a splenic laceration, grade 5. There was active bleeding to the peritoneum, but a small amount of free fluid. So any thoughts on the management of this patient right now?
Well, very nice. These cases are very challenging, right? So we have a transmediastinal and a thoracoabdominal injury. So these are one of the most challenging situations, right? Dr. Schroll, any thoughts on the case, on management?
Yeah, it's gonna be challenging. I mean, I think yeah, it's going to be tricky, right? We're worried about an esophageal injury. We're worried about possible intra-abdominal injury. Thankfully the aorta looks okay, which is probably not surprising actually, because if the patient had had an aortic injury, they'd probably be dead before they got to us.
Yeah.
But yeah, I mean, depending on resources available to me, and you know who else I have available, I maybe you know needing to you know phone a friend, a cardiothoracic surgeon, or somebody who operates around the esophagus routinely, because that's going to be a challenging potential repair. Yeah, I mean, I don't know that you need to do any additional imaging before you go to the CT or before you go to the OR. I think you kind of at this point you know it's injured, and you gotta get on with it.
Great. Dr. Gois,
Yeah.
Sorry.
Mariana, I just would like to confirm. So the EFS showed no fluid in the pericardium, right?
No. Sorry, I didn't mention that, but there was no fluid in the pericardium.
I know we have a problem in this esophageal, but I just would like to, I don't want to lose the opportunity to say something that I consider very important. So CTs are not a good exam for excluding heart injuries. We did a study, and we compared the radiology report with surgical findings, and many times the report was normal and there was a heart injury, and vice versa. So you need to take a look with the EFAST, and if the EFAST is not available, I 100% will go for a pericardial window. You cannot be satisfied only with the CT for excluding the heart injury. Regarding the esophagus injury, I think it's always a terrible situation. If I have a more experienced surgeon, I would not hesitate to call for help, like Dr. Rebecca told us, but I would begin with a laparotomy, and if needed, and it's probably going to be needed, I can open a little bit the diaphragm and try to look to the distal esophagus, but if necessary, thoracophrenal laparotomy, and let's see what happens.
Great.
Yeah, I also agree with Dr. Go that the spleen needs to get taken care of first, because that's what's bleeding. That, you know, the esophagus is a problem, but that can wait a little bit longer than the grade 5 spleen.
In this case, you know, I agree. Patient needs to go to the operating room, deal with the spleen, the source of bleeding. But at the same time, you can do an intraoperative esophagogram. I think the trajectory is low enough of the bullet that it's unlikely to be a tracheal injury, and likely in the lower, the distal esophagus. And it'd be good to know exactly where the injury is. If you know it's at the GE junction, then you can approach it transabdominally, free up the lower esophagus, bring it into the abdomen. You can primarily repair it and do some sort of fundoplication.
Excellent. A lot of ideas, a lot of different approaches, and what everyone agrees is that it's a very challenging case. So, Dr. Mariana, we are looking forward to hear what you did in this case.
Okay, so patient was taken to the OR, and at this point he was considered a transient responder to crystalloids because he was getting hypotensive. So bilateral chest tubes were placed. They started with a laparotomy. There was this splenic laceration with active bleeding. They also found a distal posterior esophageal laceration about 10 centimeters above the gastroesophageal junction. There was also a diaphragm injury next to the hiatus and 2 gastric injuries, one in the anterior body and another in the gastric fundus. He underwent a splenectomy. The esophageal injury was repaired transabdominally through the hiatus. They reported that it was not feasible to pass an nasogastric tube. It was not progressing. So they placed a mediastinal drain and also did a jejunostomy to ensure adequate nutrition in the postoperative period. The diaphragm injury and the gastric injuries were repaired. He got 2 units of packed red blood cells. His estimated blood loss was over 1 liter, and his intraoperative blood gas showed actually a respiratory acidosis, but a mild metabolic acidosis with increased lactate levels. So, any thoughts?
Well, let's see, Dr. Untracht, any thoughts on that?
Yes, so yeah, the mild acidosis and lactate level is decent, but how about a gastrostomy tube to decompress the stomach if you couldn't pass a nasogastric tube? I would have added that plus the gastrostomy, and I think you'd be in good shape. So you just did a primary repair of the esophagus, and without any kind of wrap of the fundus. I know the fundus had been lacerated, but you can repair that and wrap it around the lower esophagus, at least partially, as a serosal patch. But was that, did you think that the injury in the esophagus was too high to do that, or what were your thoughts?
It was not performed in this surgery. It was a difficult access. They reported a difficult access, and the patient was somewhat borderline in his hemodynamics. So maybe damage control strategy here.
Can you elaborate a little bit more on what the injury was actually like? Was it a transection? Did it just take out a section of the wall?
Yeah, it was a posterior laceration, a single posterior laceration. There were not two entrances, entrance and exit.
Any thoughts to potentially approaching it from the left chest? And trying to do some sort of repair over a bougie rather than just doing a primary repair. 10 centimeters is sort of approaching something where it's getting a little bit difficult to try and, bring this thing down and do something adequate. And at least that way you can make sure that your mediastinum is really well drained, because the pleura is probably already violated just from the trajectory.
Exactly. I think that I was not in this surgery, but I think that the patient would not tolerate a thoracic approach. At the same time, he was already becoming hypotensive, and it would be too much surgery for him at this point.
Right, Dr. Schroen, sorry.
So potentially then the best option for him, rather than trying to do any repair at this point, was just to drain him as widely as possible and resuscitate him, and not worry about stricturing the esophagus and then coming back and trying to give him a more substantial repair with some sort of flap to cover this thing up, I've used pleura, pericardium, after a day or so of resuscitation and doing it that way, although I'd love to hear what the rest of the team thinks.
Yeah, Dr. Schro?
Yeah, I would I think tend to agree with Milos that if I felt like the patient was too unstable to continue to do the operation that I thought would be most adequate, then I would probably try to do something damage control, drainage, resuscitate, and come back another day. I agree that, I think you want something to buttress the repair, either with a fundus wrap, or if it's too high for that, then yeah, some sort of pleura, pericardium, bring some momentum up, something to try to patch over the repair, ideally. And left chest might have provided better exposure, but obviously it's hard for us to say since we weren't there.
Dr. Adenauer, anything else?
I just it's hard to be satisfied without passing the nasogastric tube. So if I am in the hospital that has the capability to do intraoperative endoscopy, I would call. I think it could help to transpose this injury. But if it's not possible, well, try to drain it the best I can. And as Mariana already told, they were able to suture. I understood they were able to treat the injury by the abdominal exposure. But if they were not able and the patient was stable enough, I would go to a right side thoracotomy and try to exposure the esophagus. If it's not the situation, let's just drain it and try to get in a better situation in about 24, 48 hours, perhaps.
Dr.
Great.
Fonseca, was the difficulty passing the NG tube, was it up in the nasopharynx, or was it actually at the level of the repair?
At the level of the repair.
So one thing that I often do for these types of injuries is actually pass the NG tube first before I do the repair, and that way I'm not struggling to get it passed. And I'm repairing over the NG tube, and it's not as large as a bougie, but that also somewhat helps prevent stricture.
And another advantage to pass it prior to doing the repair is that sometimes it can help you to find the repair because it goes through the hole. So if it's in the posterior wall, for example, you can track the tube and find the hole, and sometimes it helps.
So Dr. Adenauer mentioned using intraoperative endoscopy, and Dr. Edmund Burke in the chat asked if there was any role for using a stent that could be passed by the endoscopy. Do any of the panelists have any experience with covered stents for esophageal injuries? Dr. Schro, Dr. Untracht, Dr. Boyce?
Yeah, I don't have that experience, but it's a good thought to get control. It seems like that would be something compatible with damage control if the gastroenterologist can work simultaneously, with the surgeons and get the hole plugged.
Great.
In my experience, they usually lead to some ongoing leak, but they, whenever possible in these cases, I think that the data would support that surgical repair is the best option, but it's not always an option. So I certainly think it's reasonable to reach for that if that's what you have.
Yeah, great. And just to clarify, Dr. Mariana, so it was just a suture of the esophagus, right? No wraps, no duplications, nothing like this, right?
Primary repair.
Okay.
And this was 2 a.m. and unfortunately we don't have upper endoscopy readily available. So this was a problem too.
All right.
Two
Okay.
layers, one layer.
One layer.
Well, something you can do if you are not completely assured that your repair is patent, because, it's difficult to do these stitches at 2 a.m. in the morning. So if you don't have endoscopy, maybe you can do contrast and do an X-ray and see if the repair is patent, because if you closed the esophagus lumen, that's a different situation.
Awesome. Thanks. Thank you very much, everyone. So Dr. Mariana, I think you can move on.
Okay, let's move on. On the first postoperative day, the patient was hemodynamically unstable, but requiring a low dose of vasopressor. The chest tubes and the mediastinal drain had minimal output. His postoperative X-ray had a small residual right hemothorax, but no residual pneumothorax. It is important to note here, his baseline albumin levels were low, 2.6. Then on the second postoperative day, the case was reviewed, this history of difficulty to pass the nasogastric tube. So a decision was made to perform a contrast esophagogram, and it showed contrast extravasation in distal esophagus to the right pleura, and no transit of contrast to the stomach on the delayed images.
Yeah, I would love to get Dr. Untracht's opinion of this. I've probably fixed about 5 or 6 of these, and I always do it in 2 layers because I'm worried about an en masse closure. I want to make sure that I find the distal edges of this thing, that I reapproximate it, and then I try and close a second layer over the top and then bring a patch over it, because I'm worried about exactly this.
So Dr.
Yeah.
Untracht.
How would you approach this now?
Yeah, exactly as Dr. Milo said, you need it's basically like a traumatic rupture. It is a traumatic rupture of the esophagus. So in this case, you need to explore through the right chest and then isolate the injury and repair mucosa, then muscularis, and then some kind of a flap, either most likely the intercostal muscle, or you can use pleura. And hard to tell exactly where the leak is. If it's in the middle, or the junction, the middle and lower thirds, or in the lower thirds, hard to tell. But you go where the contrast is. But I think it's still, it's reasonable under the circumstances. You do the best you can. You had a mediastinal drain, so there was good drainage. You had the 2 chest tubes, and there's no shame in having this injury that you picked up post-operatively, but now you can do a definitive treatment of this. If you can't repair it, if there's too much inflammation and there's too much damage, then you need to temporize and then eventually go in and do some sort of an esophagectomy with a gastric pull-up. But you want to avoid that if you can.
Dr. Schroll, any thoughts?
No, nothing really to add. I think, it's going to be challenging because now it's 2 days post-injury. The tissues will be more inflamed. So yeah, it's you need to kind of have a plan A, plan B, plan C here.
Definitely. Dr. Adenauer, any other thoughts?
Fortunately, I didn't have to take care of these injuries many times. So the only time I need to take care with something that was similar to this, I had just got out of the residency and I need to operate hiatus hernia with completely necrotic transition of the esophagus to the fundus, and I had never performed the esophagectomy. So my damage control for that non-traumatic situation was to open a little bit the diaphragm and put a Satinsky clamp into the distal esophagus, and I ligated that, and I performed gastrectomy, and I put an nasogastric tube to drain the esophagus. And if the patient survived, someone with better skills than me needed to fix that. So I don't have much to contribute with Mariana right now.
That's great. Okay, Mariana, I think you can move on.
Okay. So the patient was taken back to the OR. We started with a right posterolateral thoracotomy, and there was a missed injury in the distal esophagus above the previously repaired injury. So it is here. They were able to pass the nasogastric tube here, and it doesn't seem in bad condition. So they actually repaired the esophagus. They kept the nasogastric tube, but the patient was also taken back to laparotomy because the contrast was not progressing to the stomach. So they found a stenosis of the esophageal suture, and the suture was debrided and repaired again with a fundoplication through the hiatus. The patient kept the bilateral chest tubes, a mediastinal drain, and this time he had the nasogastric tube. He already had the digenostomy from the first surgery. Okay, so he began to improve his clinical conditions. He was stable. The enteral nutrition was started. Actually, this postoperative day refers to the first surgery, the admission day. So he began the enteral nutrition. He was successfully extubated on the postoperative day 5 of admission. But during extubation, there was an accidental removal of the nasogastric tube. But he remained well. His chest tubes had minimal drainage, and they were removed on postoperative day 9 and 10. It seems like he was recovering well, but on the postoperative day 12, he started with fever, dyspnea, worsening lab results. So again, he underwent a CT scan and a contrast esophagogram. So this is his CT scan. We can see a bilateral loculated collection in both pleural cavities. And there was a collection here in the splenic fossa, and also a moderate amount of free fluid in the peritoneal cavity, mostly in the pelvis. There. And this is the esophagogram. So the contrast was leaking to the right pleural cavity, actually to both, but mostly to the right. But contrast was passing into the stomach.
Okay.
So right now, what to do about the
So
pleural collections?
yeah, so Mariana, I would suggest you to just tell us what you did actually, because we are almost ending the session in the sake of time only. So if you can just move on, and I think it would be great.
Okay. So he was taken back to the OR. He underwent a thoracoscopy on the left hemithorax and a right thoracotomy. The pleural collections were not purulent, but they were loculated. There was a lot of fibrin and adhesions. Both lungs were decorticated, and the right hemithorax was drained with anterior posterior chest tubes. And he underwent again a laparotomy because of the moderate amount of free fluid, this abscess. So the collections were drained, and his fascia was already compromised, so he had to stay with an open abdomen, which was managed with negative pressure wound therapy. Later on, he stayed hospitalized for about 2 months. He improved his clinical condition, but he had a persistent drainage to the right chest tube, about 200 to 400 cc's per day. It was saliva, basically. His abdominal wall was closed with continuous facial traction. And he was not tolerating full enteral nutrition. He was getting abdominal distension, so we combined with the parenteral nutrition. And to address this fistula, he was transferred to perform intraluminal endoscopic vacuum therapy. And this is his last upper endoscopy. It seems that it's working. Otherwise, we would have a big problem to address.
So he's still in the hospital, right?
Yeah, the vacuum therapy is ongoing.
Great. Well, I'm sure it's going to be it's going to work and it's going to be fine. Perfect. So so everyone, so now it's 1:12, I guess, East time, right? And here in Brazil it's 3:12. So I just want to thank all of the panelists for being here, Dr. Rebecca Schroe, Dr. Adenauer Gois, and Dr. Steven Untracht. And I'm going to pass this to Dr. Milos, my good friend Milos, to end this session for us. Thank you very much.
Thank you, Dr. Mengozo. Just a huge thank you again to our panelists, to Dr. Pascual, who unfortunately we have lost, Dr. Guo from the AAST side as the chair of the International Relations Committee, Dr. Antonio, who I do not see here from the PTS side, and Kevin, who has helped organize the Zoom meeting, and everybody that has participated, Dr. Mariana, Dr. Varopas, outstanding cases, excellent reminders of all the things that we need to do for our patients, and the huge team effort that it takes to get them through these things. So on behalf of myself and Dr. Mengozo and the PTS and AAST, thank you to everybody for joining us, and we look forward to seeing you next month for our next meeting. Thank you so much.
Thank you so much.
Thank you.